All right. So with that note, let's everyone said yes, and let's show our slide presentation, and then we discuss about the case. So this is our 8th China Structural Week, valve-in-valve tower for degenerated Magna valve using Evolut FX Plus. Now, FX Plus has been introduced to China yet?
No, it's only in the United States.
I see.
Yeah, and they're going to soon, hopefully, in Europe and Japan and other parts of the world. So,
okay.
Yeah.
So yeah, I know the FX.
We had.
Yeah.
Yeah, we had FX from Europe, from Bordeaux yesterday, but not FX Plus. So this is a great case.
Yeah. So this will be the right one. These are staff. So this is an 80-year-old patient. Actually happened that why patient getting the dental clearance, patient had a bioprosthetic surgical valve in 21. No, sorry, on 2007. 2007, so about 17 years ago. So lasted good. And patient was having little symptoms before, but then what happened, developed some chest pain, shortness of breath, and have troponin positive. That time became bradycardic, dyspnea, hypotension, abdominal pain, and that time detected that patient now has a severe bioprosthetic degeneration. Originally, in 2007, patient has a bicuspid aortic valve, so will be about at age of 63. So that's appropriate. And that time they put a 21 millimeter Magna valve. And so we, with the patient body habitus, I think 21 was the best possible at that time.
Yeah, the patient is only around 70 something kilos, so it's not obese. So I think that was appropriate for the anatomy.
So how, maybe we can have just one discussion when patients, the aorta is small and patient body habitus is big, that how many times they're doing a root enlargement, putting a bigger valve?
I mean, back then, not many. Yeah. Right now, we think people realize, especially from the low-risk trial, that surgeons need to put a bigger valve in to avoid severe PPM to compete with the, TAVR. But TAVR still overall have less PPM that's been shown in multiple trials than surgery, except root enlargement. So I think that's appropriate for this case, and these patients typically have larger anatomy anyway with bicuspid.
Okay, great. And the patient then had. So that's the valve placement that time, and then did have a PCI in 21. So clearly we'll show that angiogram. Lucy Safi, our echocardiographer, will show that. A patient has a high gradient at present, and there was no AI or PVL, and the ejection fraction about 47%. And the CT, of course, showed the restricted leaflet motion, which we'll show. And the patient has been on good medical therapy. Cath was done, non-obstructive CAD. So let me just finish it. And now, Lucy, you want to just show the live, maybe echo feed will be much better. But yes, patient had a high gradient and with the velocity of more than 4, with a mean gradient of 64 and a mean of 41 and peak of 64.
So today on echo here, you can see that the EF is mildly reduced. It's globally reduced. And zooming in on the aortic valve prosthesis, you can see that all 3 leaflets, they appear to be moving, but they are all diffusely restricted in motion, and no obvious aortic insufficiency or paravalvular leak in this view. But when we go ahead and look further in the long axis, again, diffuse thickening of the prosthetic leaflets, there's that acoustic shadowing right across the LVOT from the prosthetic stent. And then there is some aortic insufficiency seen in this view, but you can see it better in the transgastric images. Here again on X-plane, you can see the diffuse restriction in the aortic valve leaflet motion. And then when we do our direct planimetry using our 3D MPR, the direct planimetry of the aortic valve is 0.97, so it's consistent with severe prosthetic stenosis. And then transgastric imaging shows that mild valvular AR, which wasn't well seen in the parasternal views because of the acoustic shadowing, so mild aortic insufficiency. And then the gradients today a little bit lower under general anesthesia with the low EF, but still when we calculate our continuity equation aortic valve area, you can get an AVA of 0.7.
Okay, so clearly, so question comes that all these cases, valve in valve, we are preferring with the using the general anesthesia TE, right? Because of TE, we have to put a the general anesthesia.
Yeah,
What about
I
if
mean,
you do ice?
you don't have to, but I think in this case we plan to valve fracture, and obviously there's some unpredictable hemodynamic changes. So I think in the context of the patient also want to evaluate PVL and AR. For example, Lucy just said that there was no AR noted on transthoracic, right? And you can do TE to see it. And with a patient like this, and especially valve in valve, at least in our philosophy, that you want to make sure you have a perfect result before leaving. And I think having a GATE in this patient, without a lot of severe comorbidities, is reasonable option and discussion with our anesthesia team.
And from anesthesia point of view, anything unusual, Benjamin? Good. So they say straightforward, no trouble, no intubation issues, and hemodynamics good. Let's come back to our presentation. So this was the TE done. Okay, now let's talk about the CT.
So you can see that this you can use Vini-Valpat's app, the aortic valve in valve app, to figure out the surgical valve, which is a 21 Magna, and the internal diameter. And this is consistent that you can see that the internal diameter is almost at 18-19, which is true ID. The LVOT is a little bit bigger. Next slide. So you can see it is a large aortic root consistent with a patient with a previous bicuspid valve. So coronary obstruction should not be an issue. We can go to the next slide. And you can see that here, really, we don't even need to calculate the valve to coronary or valve to STJ distance, because, you can see that here, the root is so big that the coronary obstruction is going to be very low, and we'll show you an aortogram as well to confirm that. Next slide. You can see that here, we just calculated just for this particular case, membrane septum is 6.6, valve to coronary distance at 8 and 8, so definitely very low risk of coronary obstruction. Next slide.
Yeah, so let me ask you, valve to left main of 8 is all right, because we always say that in the native more than 10.
Yeah, that's the height. This is the distance across the classification. That if it's less than 4, then you're concerned. Okay. Now, having said that, we are going to fracture the valve today, so that distance will decrease, no question. But this should be still plenty of room for us to do it. Now, if this is 4 or even less, then we'll be very concerned about doing valve fracture. In those cases, we might not actually choose the valve fracture. We may post-dilate instead, just to optimize the frame expansion. So this is a very important point for the audience. Don't fracture everybody. You have to check the distance, because even the distance look good now, it might not look good after you fracture. And we've seen that with, in some of our cases.
Yeah, and clearly we need to outperform the surgical results.
That's right.
This patient did 17 years.
That's right.
With surgery. So clearly the patient should not get any further surgery in her lifetime. Yeah. And so it should last at least 10 to 12 years. Okay. The femoral access is straightforward. For some anything unusual?
No, Dr. Sharma. There's some tortuosity, but the extent of calcification was only moderate, so the loops opened up. We chose the left side just because the patient actually had a right-sided hernia repair and the fibrotic skin over there on the right side, so it might be a little challenging for tract dilatation putting the big sheet, so that's the reason why we chose the left side.
And what about the sentinel point of view?
Yeah, so we try to do sentinel, especially in valve-in-valve case, and especially the etiology of bioprosthetic valve degeneration is more stenosis, which is what in this case it is. And it was a bovine arch, as confirmed on the CAT scan. We can actually see, and also on the aortogram, we did confirm it's actually a bovine arch. So we actually did the proximal filter in the innominate artery.
Can we show the fluoro now? Yeah.
We did the proximal filter in the innominate artery, but actually very close to the arch, so that it covers both the right carotid and the innominate. So we get double protection out of one. And then we placed the distal filter, which is usually in the left carotid, in the left subclavian, so that now we're also covering the left vertebral. So it's kind of like all three structures going to the brain are covered now.
Wow, yeah. This is good. The bovine arch is in our favor.
Yeah, and you can see this is the aortogram.
Yeah.
So you can see very big root. So fracture should not be an issue in terms of coronary obstruction.
And Magna valves can be fractured?
Yes.
Because not all of the valve can be fractured.
That's a very good point. That's a very good point. So trifecta from Abbott cannot be fractured, and also the Medtronic Hancock 2 valve can also not be fractured. Those are the two main valves that would not be not fracturable.
Okay. And as we know, Hassan, and of course we can ask other moderators and panelists to ask some question to us, but key is the data have shown if you cannot if you don't do a fracture versus fracture. So don't do fracture is better. And I know you have been involved in those publications and so if you cannot do but fracture you do because the valve is small. But yeah, anytime fracture patients have a little higher event rate in the TAVR, redo TAVR versus without fracture. Now then question comes is that yes, cases you do decide for the fracture, do you do a pre or post And I know the literature was kind of controversial in the past, but now many of the meta-analysis saying that maybe do a post. So what is your feeling?
Yeah, that's been our preference at Cedars-Sinai always to do post. So do you have a plan? Which balloon, if you need?
Okay, very good.
Which balloon will you use?
That's a great point. So we at Sinai, I guess East Coast, we do a little differently. We like to pre-fracture because what we found, we a couple of cases we tried to post-fracture and we're unsuccessful. Either for two reasons. One, maybe the valve is implanted a little too high, then it's not safe to do it. Or two is that despite very high pressure, we were worried about damaging the leaflets. We did not see the frame expand. So that's why we now try to pre-fracture to actually see on fluoroscopy visually that the frame of the surgical valve actually breaks, because even after putting the second valve in, it might not be so easy to see all the material involved. Having said that, you do have to be wary about acute AR. So that's why you always have to have a valve ready, your anesthesiologist ready. And so in our case, that having general anesthesia TE is the best protection for the patient.
Yeah, and we actually had one problem. One patient developed severe AI after the post one.
Yes.
So again, I think, as I said, the literature is one, but our practice has been a pre. But again, I think these are the small number of patients being done, but more and more we'll learn.
Yeah, and what we decided this case, we're going to use a 21 true. I know the valve app may recommend a more aggressive balloon, but if you are too aggressive, then you need to upsize to 26 Evolut because this will not fit. Yeah. So I think for the safety, this patient is already 80 years old, a re-op, we will just use a 21 true, and then we'll put a 23 FX plus valve in there.
Okay, let's go back to presentation, and then we quickly go to the actual performance of the case. So this basically is a degenerated 21 Magna, right percutaneous arterial access under TE guidance. After valve fracture, we are going to use a 23 millimeter Evolute FX plus. Now FX plus basically is.
So maybe let's ask the panelists there, because they have some panelists. Hassan, you want to say hello, hi, 你们好. What would you guys use in this case? Would you use a self-expanding valve or balloon expandable valve for this particular case? Let's ask the panel.
Yeah.
Yes, that's what I think that because tomorrow in our center we have a patient is 15 years after is always the similar cases. We plan to use the balloon expandable valve, but I don't know what is the preferred choice for this kind of situation. Which is better for self-expanding or the balloon expanding the valve for this situation? Which do you think is better?
What?
Yeah, our preference has been self-expanding valve in small surgical valve with the better hemodynamics because of supraannular design. But obviously, there is a patient that there's some operator experience preferences. So that's why we want to ask the panel from China, what valve do you use in China, let's say in this situation?
Maybe I think most of our patients we use the self-expanding the THV. Yes.
Yes, we just use self-expanding valve for this kind of patient, but we don't have the just you see your Evolut Flash Plus. We did not have this system. We just have Evolut R.
Yeah, in China, I think it's still Evolut R and Pro. I think that it's not, not in Pro Plus yet. So, but it's the similar feature. And Dr. Sharma, maybe you can now talk about FX Plus here on this slide.
So remember, one of the biggest disadvantage of the self-expanding valve, despite giving a better lumen, and we know that from the smart trial that for a small annuli actually gives a better hemodynamics. And then even at some data, the meta-analysis of the valves have shown that you have a better lumen, effective aortic orifice, and lower valve thrombosis of the self-expanding compared to balloon expandable. So, and particularly when you are using, although there is no clear-cut randomized trial showing benefit of one versus other, because we need at least to have benefit at least 3 to 5 years. and there's no trials have done latent and all those have been a 1 year, 2 year follow-up. We need to get to 4 or 5 years. Now, one of the disadvantage or one of the biggest issue for valve-in-valve is the coronary obstruction. And that is why many times patients, even at the age of 85, we have sent patients to surgery because there was a chance for bilateral coronary obstruction and patient has a surgical deterioration, and patient STS was just about like 5, not extreme risk, like intermediate. So key is the coronary obstruction is very important, and one of the big issue of the self-expanding is coronary obstruction, particularly if you coronary access, particularly when you patient comes back with a CAD. So what they have done is, besides making the Pro Plus, FX, and now FX Plus, that make some 3 large the 4 times larger orifice of the valve without compromising the integrity. So that's the key. You can make a bigger hole, but if you make the valve weak, it's not good. But purpose there is that you have nice alignment, and we'll show that here in this particular case, and we'll do the angiogram after the deployment also, that how easy will be to access right and left coronary. As shown here, you see that the orifice is much larger, and so FX Plus, there is a slight change in the delivery sheath also, and then these are, little more redesigned capsule and so, but biggest thing is the valve. That you have that orifice window height and dimension based on what size it is, whether 23, 26, 29, and 34. You can see there, and the purpose there is the demonstration is that how easy will be to align to the orifice, and that's where the whole issue will come down to. And this is, see that, this is a fluoroscopic visualization, and I can tell you, be honest, that in the beginning I couldn't figure it out. We used to do a lot of fluoro. I think we probably developed a lot of high radiation when trying to figure out what it is, but then we understood. And this is actually a nice fluoroscopic visualization of the FX Plus. And now you can see, most important is the left coronary, left main, and this will be aligned with that. Anu, now it's yours. Tell us what you're doing now. Let's go to fluoro now, please.
Okay. I just have a question. If we use the self-expanding valve for the for this kind of patient, should I implant the valve more higher to achieve better hemodynamic?
Yeah, that's a good question. So it depends on whether you plan to post-dilate or not. If you plan to post-dilate, don't implant too high because then you risk pop-out. So we typically, the nice thing about Evolut FX, you have the 3mm marker. So during this implantation, whether you're too high or not. You don't want to be too high. And but at the same time, like you said, you don't want to be deep either. So we typically aim for about 3 to 6mm before we release. But of course, sometimes it's difficult because the valve can be very stenotic. Our preference has been, if it's a very stenotic valve, not much AR, we'd like to pre-dilate a little bit, maybe 18 small balloon or 20, not fracturing, just so that we can cross, especially if you don't plan to fracture, because sometimes it's very hard to cross these surgical valves, especially small valve with big root like this bicuspid situation, and on top of that, let's say horizontal aorta, because then your catheter will be biased to the outer curve. So to your point, we don't implant too high, we just implant right. So we want to post-dilate afterward. Even if we don't fracture, we just post-dilate enough so that you optimize the frame. Because we've done some CT, and there's been some data showing that if it's a stenotic surgical valve and you just put the self-expanding valve in and you don't post-dilate, it's underexpanded, and that can impact on HALT and durability.
Okay, I know what's happening now. Yeah. So
Yes.
We have AR1 and surgical valve. We try to go to the RAO view. Normally we like to cross an LAO view. We're trying to see.
Yeah, they can be quite difficult to cross. I thought I saw you.
yeah, earlier they went in.
At one point.
Yeah, no, they went in, but I said, no. I said, take it out.
Challenging.
Yeah, I told them you have to show and demonstrate it, so I asked them to take it out. Sorry for that.
Yeah, for the surgical degenerated valve is become very difficult to close the valve.
Yes. So you showed very clearly the design of the FX Plus.
Yeah.
And I know you did some innovation at Mount Sinai on the commissural alignment, which is very, very crucial to this innovation, because the innovation will not work unless commissural alignment. So can you comment on the commissural alignment?
Yeah, sure. So actually, that's a great point, Hassan. And so the premise of these large cells only works if you have these large cells facing the coronaries, right? And so before, I would say, 6 years ago, no one was thinking about this concept. They just want to put a valve in, get in and get out, make sure the patient survive and not have a stroke. But now, at least in the United States, we're doing TAVR in younger patients. In fact, almost half of the population in some part of the United States, they're getting TAVR already if they're age 65 or younger. So lifetime management is very important, as Dr. Sharma pointed out. So what we plan to do is that what we discover with, at least with the Evolut system, even with the R or Pro Plus, or Pro rather, that you can put the flush port at 3 o'clock, and then when you track the delivery system across to the annulus, whether it's native valve or surgical valve, that's no good. That's no good. So
We got.
So that's.
Sorry.
Oh.
Yeah, we lost.
No, they said they lost.
Briefly.
Oh, okay.
Very briefly.
Yeah.
Now we have you.
Say it again. So we said.
So we were just talking about the technique of commissural alignment with the Evolut system. We've started doing this with the Evolut Pro and Pro Plus. So this is also applicable in China as well. So you don't have to wait for FX or FX Plus to do this. So what we do is that we put the flush port at 3 o'clock at the gray handle. And then when you advance to the descending aorta, your head marker should be the outer curve of the descending aorta in an LAO projection. After that, if it's in the inner curve, then it's no good. So you have to make a rotation to the outer curve if you can. The two spine of the Evolut older system is a little harder, but it's doable. And then you just trap the delivery catheter up to the annulus, and it should still maintain the same relationship. So if that's the case, when you do the cusp overlap view for your deployment with the Evolut system, your head marker should be facing you. And when it deploy, you should have commissural alignment, I would say, at least with your current system in China, about 80% of the time. But the FX system is better because of the single spine is about 90% or more. But at least that's a good start for your system. I'm not sure if other self-expanding system in China can do that, but Evolut system, you can definitely try that.
And now you see that they crossed it now. They crossed with the the AR2.
Excellent.
Yeah.
Excellent. Well done.
AR2 or AR1, what was the story there?
No, this was AR2. Usually we like to go to RAO view, but we saw that we could not in RAO view, if you see, better projection, but we have to go back to LAO.
Yeah. Yeah, go ahead. Yes, please. Question from the panel?
I mean, if this patient have aortic regurgitation,
very little,
no,
very little.
Mild. You saw on the echo.
That's also on TE echo.
Yeah,
but
only mild.
Transthoracic was almost none.
Transthoracic almost none. Yeah.
So it's difficult to close because it has no aortic.
Right.
That's right. And this valve has high gradient as well. And what's difficult is a small surgical valve.
That's right.
We've seen that like a 19 surgical valve with a big root is very hard to cross because you have a lot of space around the root. So those are very, very difficult because, it's not like a native aortic valve. Very different.
And sometimes it is tough also. I can tell you, those who have attended about 6 years ago, our TCT conference, I would not say the name of the operator, they tried for half hour. In the design time to cross the valve, could not. And they went off the screen without crossing the valve. So sometimes these valves are a little difficult.
But having said that, Dr. Sharma, you tried that using a guy with more support. Right. And what's the secret trick? You can tell our Chinese friends what special wire you use to cross.
So 18 wire.
V18.
V18.
Yeah.
So question is, if you are V18, yeah. So so we say that you could do 2-3 minutes of this. If not, we are regular the Terumo, stiff shaft straight wire 38. If not, then you go with the V18 and particularly use the guide catheter. In that situation. So, original, if people may not remember, in 91, 92, 93, the technique of crossing the aortic valve was pigtail catheter, and there used to be the adjustable straight tip, Teflon. That used to be the wire because straight one very simple. So we did a 3 center trial, comparing the conventional technique versus the straight Terumo, the 38 stiff shaft. And we found that it was decreased, that crossing time from 2.5 minutes became 53 seconds. So less than 1 minute. Now, only trouble we had was the patients who had prosthetic surgical valve, like this. That time there was no TAVI valve. But prosthetic surgical valve was very difficult. Many a time took 8 minutes, 10 minutes, and like this kind. Large root, small valve, very tough to cross, very tough to cross.
Yeah, so the other thing that reason why we use TEE as well, sometimes we can use TEE to help us to make sure the wire is center on the long axis. You can explain today, we didn't have to do that, but if it's very tough, we actually ask our echo colleagues to help us as well.
Okay, and we are ready now. Tell us where we are.
No,
where are you now? Tell us what we are doing.
Now we exchange it to pigtail.
Okay.
And then we'll go with our...
show the hemodynamics one side? No. But they should show the hemodynamics.
I have a question.
Yes.
If we measure is there a higher gradient between the LV and AO, how can we identify the gradient is from the aortic stenosis or the small adenos?
That's a good question. Lucy, you want to answer that in terms of how do you differentiate between, I guess, what PPM versus a prosthetic stenosis based on echo versus hemo?
Mm-hmm. Yeah, I mean, that's such a great question. I guess the easiest way to answer that is you could just do a direct planimetry, and you can get the direct valve area, and that will give you for sure whether or not there's aortic stenosis.
Tell them to put it
you can do that with 3D volume sets, and then just do a direct telemetry like I showed you on the baselines. Other than that, you can do pressure gradients. You can do a pullback on cardiac Cath, but on echo specifically, pressure recovery is an issue in these patients, and it's usually the little old ladies with the small aortas that do have issues with pressure recovery. So it's a little bit more complicated, but the easiest way to do it is just to do a 3D direct planimetry.
Yeah.
So now what? Keep telling what you're doing now. What wire?
Exchanging it to Safari.
Okay. It's a Safari wire now. We exchange with the pigtail as you saw the steps. Cross with the AR2. Okay. Then 35 wire exchange Teflon, and then we change it to the Safari wire. Now they are ready to use a 21 true balloon, and then we are going to connect the indeflator to really fracture it, right?
Let's show the audience the setup of the valve fracture apparatus. Now you do need a non-compliant balloon. I think not every country has a non-compliant balloon. So if you don't have one, like Japan, for example, they cannot fracture. That's the reason why they don't fracture in Japan. But in China, I guess you have the opportunity to fracture.
Now, do you have the valve ready?
And valve should be ready at that time. And I'm sure with the China, knowing that one of the your China-made valve is one of the common valve used in China, just like in India. The My valve is the most commonly used valve. Despite all these valves are available, Evolut and our Sapien. So key is that you need to have a non-compliant. And this is the multi-layer, the balloon.
Anesthesia team will fracture, so my QAR, okay? So you let the anesthesia know.
So
and you put can we zoom in here and show the setup, what it looks like here.
So just focus here.
21 true.
Yes, that's right. True. Yeah, we don't want to be too aggressive, right? Because of the we will have to upsize to a 26 Evolut if we go 22 true. So
so what we are going to do is we'll inflate with the syringe first, and when we know it is fully inflated, I'll quickly change and then use the indeflator.
Okay.
Yeah, and then you just dial up to however pressure, high pressure, and you actually look for fluoroscopically, and you tell the anesthesia you'll be a long pacing run, okay? Because it sometimes does not fracture right away. You need to actually really crank it up. So
Benji have a P ready also.
Okay, Benji, ready, please. And then
start
ready.
pacing.
150.
150.
Slightly low.
Let's see how the good. Pressure is good. Go for it. Oh,
no, went down.
150, no. Okay.
Pull back.
Go.
Okay.
Go.
Pull back more.
Good. So lock it in.
Okay,
so now
I'm going to lock and I'm going to go crack it.
Sine. Go. Good. Yes. See? You see that? Yeah. Okay, good. Yep. Okay, off. Pacer off. Back up 80. 80, please.
Come. Okay. Get the valve.
Okay,
How much,
pressure. Yep.
Sure.
How much
Okay.
pressure training is the truth?
I went to 20.
Okay. Pace it back up for a minute and see how the
Yeah,
pressure
see,
looks.
on the indiflator.
On the indiflator by.
How can you
Let's
see?
go Val quickly.
How can you see the annulus is fractured?
We'll show it
show you
afterwards.
later, we'll show you
Let's,
later. Yeah, let's
the
finish.
pressure is coming back up, which is nice. Actually, it's a good sign.
Let's put a wire on.
Let's-
We
let's-
sedate it. We'll
yeah.
show you that exactly.
Yeah. So this is the
Move
key.
Quickly.
Yeah, you have to move quickly.
Yeah, okay.
Are you concerned? Is there some
Wire.
regurgitation or?
So you can see the head marker here. No, pressure is good now, actually. Pressure is very good. So we actually rotate it from 3 o'clock to 1 o'clock to make, okay, we have to see the sentinel now.
Wire.
So you want to make sure the sentinel does not get dislodged as you cross with this system. Okay, so we go slow. See, perfect. Okay, so you can see the head marker is still at the outer curve.
Pull the wire back.
At the with the LAO view, and now we're going to cross the valve. Watch the wire. Okay, so there's no defined view to look to do an Evolut deployment. So we're trying to get a view that has no parallax between both the Evolut system and the surgical valve, because that's how you can see the depth. And so see up, please. So sometimes you will not be able to see to do that. So we're trying to find a view, especially pressure is stable, so we can take our time to figure this out. So the thing is that might not be easy today to do it. So let's see.
I think it's okay. No.
Yeah, because maybe this one. Maybe this one. Have a little bit. Okay, maybe this one.
No.
Because,
Earlier was better.
Yeah, here.
Okay, come. No, let me see.
Because now you have a parallax on the
Okay,
surgical frame.
No,
Can we? Let's see.
I think you're okay there. You see this? Let me go in.
Yeah, maybe this, like this, maybe.
Yeah.
Yeah, but that's a very lot of parallax. So okay, we could try here.
Okay. Now,
Okay,
parallax on the
150.
surgical valve, you see?
These are the 3 markers of FX.
Yeah.
Good.
Anchor.
Oh.
Okay, 100, please. Okay, so now the key is that make sure you did not miss the surgical valve frame. That's going to be the key. So we go back to the parallax. So it's actually quite deep.
Yeah.
Really fast and
Yeah.
After the valve.
excellent.
So we're going to recapture. Okay, 150.
Can we use this view?
Yeah,
right?
we'll use this, but this is actually good now.
Okay,
So the
so I want to
markers
pull
are
back.
pushed
Advance with the wire.
Not yet, not push the wire. Good.
Yeah.
Okay, good. Good. There you go. This is good. Good.
Okay.
Very good. Okay,
Are
100, please.
Are you sure this
Yeah,
dot?
that's good. Okay, so now we're going to do a cine to make sure we don't miss anything. So let's do a cine here.
You want to magnify? Okay.
No, okay, so hold on one second.
No. I think one dot is up.
Yeah, let's see. So that key with the dot, the nice thing with the dot is that you want to make sure, you can see one is too high.
Yeah.
Right, you
That's what I
agree?
said. One I agree.
So
that's
now
too
we're
high.
going to try to do that. Well, 150 again. So we'll fully recapture, just to make sure.
Okay, no.
Okay, good.
Oh,
Okay,
wait.
What?
Okay, good.
Going.
Going.
I'm about to go in a little bit. No. Okay, go.
Go,
I think you have
pull
to
back.
go
Yeah,
a little deeper.
Yeah.
Yes, I think now we have it.
Yeah.
Yeah,
Okay, 100, please.
Yeah.
Sometimes.
Yeah.
Yeah,
long
Okay,
pacing one.
100.
Long pacing one.
This looks
You want to lay out around?
I mean, we know 2 out of 3.
good.
Yeah,
Yeah.
2 out of 3 is in. 1 is a little high.
Is it
We'll
high?
do a dry cine. Dry cine.
No, it is high. But high means I.
But
No,
you
we,
still
we,
okay?
we just made it here.
Yeah.
Good.
I think
Looks
we're
good.
okay.
But
Okay.
Yeah, go to another
you
view.
fractured,
Yeah.
Come.
What's that, Sophie?
this is advantage of
One.
fracturing before, I guess, because
Yeah.
you can
Well, the
land a
fracture
little
before.
bit higher.
Yeah, number 1, but also sometimes if you don't fracture with the mismatch, it's very hard to get to the right depth. You end up, too deep or too high. So,
Yeah.
Looks good.
no, yeah.
Hmm?
No,
So
2.
those
No,
markers
hold
are-
on.
1 or 2 is high.
No, this is the surgical valve.
Yeah.
There's no parallax now. That's the most important thing of the surgical valve.
Hmm.
And you can see 2 out of the 3 are below.
Correct.
So I
Yeah.
think we should be okay. We just have to make sure positive tension will. Okay, Benji, we're going to pace at 180, okay?
Wire back.
wire
But
back.
then we understood we
Yeah.
should not post.
Yeah, we'll no post it.
Okay.
We can just.
Yeah.
Okay, let's 180, please. Long pacing run. Push forward, please.
Yes.
So I'm going to do a very slow release because you don't want to pop. Good, good. Okay, all right, it's released. Okay, 120. Watch the wire. Leave the wire in.
Leave the wire.
Get the pigtail ready.
Yes.
Good.
I think it's good.
Okay, it's good. It's a good depth, actually.
Yeah.
Okay, I'm going to recap. We
It
marry
looks
now.
better now. Once you released.
Yeah, back up now, please. So let's look at the parallax.
Perfect.
The valve.
So
was
now you can see actually when it release,
Thinner now. Beautiful.
the valve has tilted.
see
the
it's
right
all right at the below the ring because there's always a gamble because
yeah.
of the system. So I think we can even pulse slightly with the same balloon.
Yeah, we should do it.
Yeah, because now you can see how. No?
Let's do the hemodynamics
Can
first.
you release it?
Yeah, yeah.
So if the gradient
It's
is in
up.
single
No,
digits,
did you-
then we
Yeah,
can
we
leave
capture
it.
already,
But
but
the
maybe I
gradient is
overcaptured.
9, 10 plus, then we should post dilate.
Oh, here, yeah. Sorry, 1 second. 1 second. Yeah, good. Go.
So,
Yep.
Dr. Sharma,
Yeah.
you
Wire.
mean the
Pigtail.
gradient on hemodynamics?
Yeah, hemodynamics, yeah.
Cath,
Yeah, because echo will tell us that 12, 15 millimeter gradient now. They always are like 5, 10 millimeter higher, right? That's your experience also?
Yes, you're absolutely
Yeah.
right. So that's perfect positioning.
Yes.
It looks absolutely
yeah.
perfect.
Yeah, I think the nice thing about the FX system is that you can see the depth. You know, sometimes it's very hard when we still use Pro or or Evolut R. But I think now you can do that. Oh, we're going to do post dilate, right?
No. First we are seeing the gradient.
Okay,
The gradient
gradient
is
first. Yeah.
good.
Okay.
We don't know.
Theoretical, yeah.
Can we
Because
check,
it's a little constrained there.
whether the patient is commercial or line?
Not yet. We'll show you. Yes, it looks good actually. Actually, this is a good view to show you the alignment. After they put the pigtail in, we'll show you.
We can know how to check.
Yeah, and we'll show you about the fracture too. Yeah, 'cause we have a little time now that we can take a breather because, like you said, if the patient was actually stable, but sometimes you can see the patient is not stable with the AI, QAR actually. So the key is that you look at the surgical valve, you line up the surgical valve frame here. This is the cusp overlap view. And what you want to see is one commissural tap on the Evolut here, facing the right side and the dot. So let me cine now. It's a little bit under constraint, so but you can see. Let me just go to another view here.
Looking at this.
So this view is really show you the big cells, I think.
Yeah,
Let me just
yeah,
see
it
it.
is showing it there. Yeah.
Yeah, because remember this is in a surgical valve, okay? So the big cell, you see that there?
Yep.
Right there, okay? So you know that, yeah. So it's a little bit off. Yeah, so it's a
Beautiful,
little
yeah.
off, but it's it's okay.
Yeah.
Right. So you can see.
Very clear for
Yeah.
that cell.
Right,
and look-
Align with the
Yep. And look at the hemodynamics, no gradient right now.
Yeah. But I think
And
we should.
Lucy, what do you think from
We
your
should
side?
not. You want to post?
let me
I
check.
Go to the
not.
hemodynamics. Yeah, we should do it. Okay,
do it.
so show the echo first. Echo.
Let's expand more.
Yeah.
You can see. I don't like the constraint here.
Can
You
we
can
show the
see
echo
the-
now? Yeah.
Okay, beautiful
There's
leaflet
a gap, a
motion.
little bit.
Yeah.
Nice flow into the left main, and then
I
no
think we should-
PBL
I would post.
on first look here, which is great.
Same, 21, go.
And then
Good.
looking at long axis.
Very good.
Again, no PVL seen on long axis.
Yeah,
Good.
I think it's excellent.
Same.
Excellent.
So I can tell you that based on our experience, before we had done fracture, we never, for like 5 years, we were not fracturing. No one was fracturing.
Right.
It was much harder to put in a valve because it's a smaller internal diameter. Even with a 23 in a 19, if it's a 19 valve, forget about it. It's much harder to control the depth. But the nice thing about the FX, you can see the depth much better with the dots.
Yep.
We used to have to go spin around and look at everything else, but you have to make sure as long as 2 of the 3 dots, you can see that here is below the surgical valve frame, you're okay. Actually, let's show you the fracture one now.
Okay, go back
Okay,
and floor
ready for the show the nothing. Are you ready to see the fracture here, right here?
3 to 4. Yeah,
Okay, look at this. Okay, see?
that's it.
Yeah.
In
Did
the
you
end,
see that the left side of the screen? The left side of the screen.
Oh,
The difference.
Yeah, I see.
Yeah, you have to you have to cine to see it. Otherwise, you miss it.
Yeah.
Especially the other surgical valves.
And
you see the pressure drop on the indeflator.
It went up to 20 and then, exactly.
And then goes down. And I
Yeah.
just want to be a disclaimer on that, that of course, your group from Cedar Sinai with the Chakravarti and of course your Raj Makkar and yours, they shown this fracturing technique. This all in 4 or 5 years, and now initially people were concerned, and I'm glad that we have this new addition to our armamentarium to really make the surgical, even a small surgical valve, bigger valve, and then put a bigger self-expanding.
Mean gradient on echo is 5.
Nicely.
So this could be controversial, but so now actually we had just recently on Tuesday did a live case for TAVR and TAVR, talk about the same situation, optimizing the valve that you put in to for durability, not because of PVL or because of gradient, but the frame. You can see the surgical valve with the Evolut. The Evolut looks a little underexpanded, you know. So that what we're doing now is just going to touch what we call touch up. And we did that a case actually with a failed Sapien. We put an Evolut in and we pre-dilate to the landing zone and then post-dilate as well.
Okay, 180.
Okay, 180, long pacing run again. High pressure is real. Okay, good. Look at that. Yeah.
Oh.
Keep pacing, keep pacing.
Keep pacing, yes.
Okay.
Okay, off pacer. Give the pigtail. No,
Pigtail.
let's do it with the pigtail.
So you see the expansion with the 21 true balloon. There's a little recoil, but you can see on the left side of the screen, I don't know if you appreciate that compared to before, we'll show it. There is a bit better apposition of the Evolut frame with the surgical valve frame. That was not there before. So again, you saw that mean gradient was 5 on echo. There was no gradient on hemodynamics, but we still like to do this to make sure the frame is well expanded, because we've seen and we know that in other papers that have been published that if the valve is underexpanded, there's more risk of HALT. And Hassan, obviously, you've done a lot of seminal work in that area, so you can comment on that. And it can affect durability and maybe even mortality now.
Yeah. Yeah, that's now even we try to predict the HALT.
Yes.
But it's more challenging. But definitely
the aortogram.
Constrained frame is contributing. Absolutely.
I need a wire.
Wire.
Coming up.
Not this one.
So I have a question for Dr. Sharma.
Yes.
So very elegantly, you showed some recapture to optimize, and this is one feature of the device. But how many recaptures you feel comfortable? Is there a limit or some guidance? How many recapture? Or that's really just the company concern?
So the company used to be in the trial actually used to be like after 3. So 3 to 5, I mean, usually it's we don't go more than that. And understanding now, actually, particularly with the FX, that you have those markers. So we know that recapture may require because you are on the outer curvature or small in the lesser curvature. So after 1 or 2, when you see the valve is tilted, you may want to put in selective direction. So I would say that we have done few times, like maybe 5 times recapture, but we have not taken the valve out because we did a few the capture in the trial. We actually had to take that out. I don't completely recall. It was more than 3 or 5. That in that time, during the core trial, we have been right from the beginning. We did the first case in December 2010. Right. That if recapture more than that, they wanted us to take the valve out and put a new valve just by recapture.
Yeah. Yeah. So we can show you others views as well in terms of the cells.
GL4 diagnostic.
Yeah. So
3.5. Good.
So this is what we call a center X sign. So you can see this overlay of the frame, but on the center of the frame, you can see that the X is only one X, so then know where the big cells is. So it's actually pretty well aligned on the commissure. Not perfect because this is a valve in valve, but still good. So.
Yeah. I have another question. Can we implant the valve directly and just do the post-dilation for the fracture?
Yes, you can do that. We talked about it. There was the controversy, and do you fracture after or before? So if you fracture after, the benefit is that you have a valve in place already. and you actually they show some data both balloon expandable and self-expanding that they have better hemodynamics. But if you implant the valve too high, after release you cannot fracture because you're gonna pop out. And two, if you fracture afterward, you do have a risk of injuring the new valve leaflets. And we have one case that happened, and we have to put another valve. So now the patient have two valves inside a surgical valve, and worse that we couldn't fracture the valve. So it's not good. So because of that, we made a decision in our program, at least. I know other programs do post. We like to do pre, but we also like to. You can see here we post dilate just to optimize the expansion, to optimize the hemodynamics as well. So we gotta do it before and after.
Okay, this is good advice.
I have one question. I think this is perfect. So that's what I concern. We do the fracture dilation. What we worry about is hemodynamics. So what's the measure we do to prevent the circulation collapse?
So if you fracture before and the patient's blood pressure is low, you have to pace the patient because the reason is acute AR. So acute aortic insufficiency. So you need to be able to pace the patient, have anesthesia support you. Good. And the most important thing is to implant the valve quickly to 80%. So take care of the AR. And then once you do that, remember this Evolut valve functions after you reach past the rumble at 80%. So the valve should be fully functioning. So you can then take a deep breath and assess the depth because the AR should be at least controlled. Then you decide what the depth will be before you decide to recapture. So that's kind of the trick. That's why you see our technique, very fast Evolut deployment. We look at the initial flowering, and once it flowers a good place, we quickly go to 80% for that reason.
And you see that from the large hole, we are able to put a JL catheter. You need a bigger catheter here. This is a different thing.
Quickly to do the coronary access.
Yes, that's correct.
Very easy to access to the coronary artery.
That is correct. So this is a big addition. So I think the data of the SMART trial and the FX Plus has changed the little landscape of Evolut used in America. As you know, that used to be about, I would say, mid last year, it was 72 to 28. The 72%, 26 actually, 2% are the other valves and some investigational. The 72 used to be Sapien and 26 the Evolut. The latest data, according to company, we don't have the TVT data yet, that its number is about like 76 and, it becomes 68. And use of particularly of the small valve, in a small orifice, Evolut number has gone up quite a bit. So instead of having 26, they are like about 30 to 31% of the market share, and which is very big because it's 8,000 valves per month in America.
Very large.
Now they are closing the Sentinel.
So, I think you use the thermal protection system. Do you use this in other cases?
Yeah. So if it is possible, one of the biggest limitation is the tortuosity of the great vessel. So overall in our data, overall, we actually, maybe few percent we went down after the PROTECT trial, but clearly we went back up because the disabling stroke we saw was completely decreases with the use of Sentinel. So right now in our lab is somewhere around 50%, you can say. It's between 48 to 52.
Yeah, so what we're seeing is that sometimes the CT scan might be deceptive. Because the patient, actually, your hands are like this, so you straighten out the arch vessels. But when you do the procedure, you cannot have the patient's arm like that. So actually you see much more torsion. That's why we do the arch angiogram, just to make the final call. And we've done over 1,000 of these now that we're going to plan to write up for publication. But also, as you know, a lot of patients now get radial cath. Right, radial cath. So sometimes you cannot get right radial access because of previous injury. So not everyone is suitable.
But you say that if the latest data came in circulation intervention from the TVT registry, age of 23, they included, of course, the Procedural also. So that time, overall, use of the sentinel device in America is about 19%. And the hospitals, about 36% of the hospitals of the 850 which do the TAVR, only 1/3, little more than 1/3 uses the sentinel. Other 2/3 don't even use the sentinel because there is added cost. But if you think about, the cost is about $3,100 and the reimbursement is about $2,600. So you lose $5,000. $500 each case, and everybody is so very cost conscientious in terms of keeping the contribution margin of these valve procedures, and so key is the about 35% centers in America overall central use as per the TVT registry. As of the second quarter of 23 is about 18%. Us is about 50, and we want to use it in our age. It's a default approach. So if we did not use the sentinel, the Cath report fellow has to write that why the sentinel was not used. Whether it's a radial access, tortuosity, or we tried it, did not happen. What about Hassan? What is your experience there? I know when you used to speak to Raj, he was saying every case.
He used to use every case, but the negative trials were, a little bit surprising to us. Even in bicuspid valve, data was not so striking.
Yeah.
But still in bicuspid valve or young patient or prior stroke, we know these are risk factors, so we still use it, but not so much as you say Raj used to use in every case, but then following randomized trial, not so much. But that was really just fantastic case. All of you showed really the skills of Mount Sinai, and I understand because we have excellent fellow. Our best fellows are from Mount Sinai. Denizen, he says hello from here, and a really excellent relationship between. Well, I know you and Dr. Raj, you call it Sinai East and Sinai West. Very strong collaboration between both centers, and also I want to thank Medtronic team. I know very well there, Natalia and Tana, really excellent. So you have really beautiful demonstration, Dr. Pan. Dr. Lee, do you have any comments or final questions for the Mount Sinai team?
Yes, I very thanks for giving us this very wonderful cases for us, for all the Chinese audience. And this is my first time to see the flex live cases and the live device. And I will to edit this video maybe 5 to 10 minutes and to broadcast and to educate many Chinese audience after this meeting. So thank you very much. Give us those so wonderful cases.
Beautiful. Thank you. I think the fracture procedure gave me very deep impression. So tomorrow, I think I have more confidence to our patients. Thank you. Thank you.
All right. Okay. Then we are right timing. If everything good, we will thank everyone for the opportunity and Hassan for great moderation. And we thank from the Mount Sinai team, from the Cath lab. And you carry on with your further meeting. I think this must be the last case of the day for there. But I know it's the entire week. Exactly. Education goes on. Beautiful. Thank you very much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.
Thank you.